I want to thank the organizers for the opportunity to speak with you. It's really an honor to be able to talk about cholestatic liver diseases, particularly what's new in PBC and PSC, and there are some interesting changes occurring that practitioners should be aware of. Here are my disclosures. So what I wanted to do was frame our discussions today with cases. And so our first case is a 55-year-old asymptomatic woman who was referred for abnormal liver tests found by her PCP on routine labs. Her ALK phos is 285, with the upper limit of normal being 100. ALT 53 and AST 49, both with upper limits of normal at 30. The T-billy was 0.6 and albumin 4.2 and a total protein of 7.6. Her abdominal ultrasound was normal. Her only past medical history is hypertension. She takes lisinopril for that. And her physical exam was completely unremarkable. So given the lecture today, as you might imagine, this is heading us down the road of possible diagnosis of PBC. And I think it's always good to go over again the societal guidelines and what they say in terms of what is necessary to make the diagnosis of PBC. And it's important to know that it requires only 2 of 3 criteria: cholestatic liver enzyme tests, and of course that's how most of these patients are finding their way to our practices because of the abnormal liver tests, and positive antimitochondrial antibody. And it's important to know that the AMA can be found in up to 95% of patients with PBC. An important point to realize is that the titer of the AMA does not matter. If it's positive, it's positive. So in that context, that's important. Another really important point is that in the 5 to 10% of patients who will be AMA negative, but you're still suspicious of PBC, we find that 30% of those patients will have what we call PBC-specific anti-nuclear antibodies. And the 2 most prominent ones are anti-GP210 and anti-SP100. Those are also adequate for diagnosis in the absence of an AMA. And then the third possibility, third criteria, is consistent liver histology. Other findings to keep in mind in your PBC patients: they will have nonspecific ANAs and smooth muscle antibody positivity in about 50% of your patients. So those should not be distracting you, and nor should they necessarily be leading you to think this could be overlap. We feel like overlap is now being diagnosed much more commonly, and often inaccurately because of overzealous reads from pathologists. The other thing that's good to keep in mind is that in PBC, the IgM is often elevated, whereas, of course, in autoimmune hepatitis, it's the IgG that's elevated. So just something to keep in mind if you have an SPEP in that data. So back to our patient. Their testing showed that the AMA was positive at a ratio of 1 to 160. 1 to 40 was the cutoff. Another important point to know is that either immunofluorescence, which gives you titers such as this, or an ELISA, which will just give you an absolute number, are adequate for the diagnosis. So what is the difference? Well, most people still feel that immunofluorescence is the gold standard test, but the ELISA is automated, much easier for labs to do. So we see more and more that the ELISA is the one that's being done. It's probably not quite as good as immunofluorescence, but easier. In our patient's case, in fact, their ANA was weakly positive, as was the SMA. They had an elevated IgM, the normal IgG, and they had a FibroScan done, which showed a KPA of 6.2, and we'll come back to that in a little bit. So with our patient, we've now made a diagnosis of PBC. So what is the appropriate treatment for our patient? The cornerstone of PBC treatment is urso. And urso, as you all know, is the only FDA-approved therapy for 25 plus years. A key point, clinical pearl, is that it's essential you provide the appropriate weight-based dosing, and that's 13 to 15 mg per kg per day. I typically give it as BID dosing. but no one's shown that Q-day dosing is any less effective. So if your patient says, I can't remember to take my second dose a lot of the time, they can do it once a day. The positive impact on URSO on PBC outcomes is absolutely clear. This was a kind of a remarkable study done that looked at decompensation and transplant-free survival in patients with PBC over time and clearly showed the impact of URSO. So to give you the right context, PBC received orphan drug status in 1987 and full FDA approval in 1996 for PBC. And what they did is they looked at both of those endpoints, decompensation and transplant-free survival, over the decades. So decades clearly before URSO, just as URSO was coming available, early on after URSO was available, and finally as it really was being used quite commonly. And look at the way that the graph has changed. So the improvement was really quite dramatic. Likewise, when you talk about transplant-free survival, you can see that URSO groups do much better than those earlier decades pre-URSO. So URSO is clearly of benefit. So here's our patient. We start them on their weight-based URSO. They remain asymptomatic. Here are their baseline labs that we already mentioned. At 6 months, the alk phos has come down to 192, ALT to 35, AST to 33, and the ability 0.6 to 0.5. And then at 12 months, the alk phos has come all the way down to 138, normalization of transaminases, and ability now down to 0.4. So the question for us to answer, the questions for us to answer are, did our patient respond to URSO? And how do we formally define response, and why do we need to? And so this is important for you to have in your mind a framework for how you're going to assess if your patient is an URSO responder or not. There are many validated response criteria models to assess response to URSO. They all are validated, so it doesn't matter which one is used, but I'll highlight a few points here. You can see that all of them but the Toronto criteria are assessed after 1 year of therapy, whereas Toronto was 2 years. Almost all of them focus on the alkaline phosphatase as an important part of it. Barcelona, you need a decrease of greater than 40% from baseline or normalization. The Toronto one, then this is a magical number, 1.67 times the upper limit of normal that you'll hear over and over in the talk today. The Paris 1 criteria looks at alk phos less than 3 times the upper limit of normal. So you can see there's great variability here and all different permutations. So, but pick one that you might use. And I'll keep coming back to this one. That's a good number to have in your head. So what did the response mean? So if this is from the Paris 1 criteria study, and what they showed is that if their patients met their criteria on URSO, the responders did every bit as well as the control population. Whereas if you're a non-responder, I think we can all appreciate this is a survival curve none of us want to be on. So these are a group of patients who desperately need additional therapies beyond URSO. Another one that I'd love for you to keep in the back of your minds, because this is in the hepatology world, particularly in those of us who do a lot of this type of work, now pay a lot of attention to the bilirubin. And what do we look for? Well, if you have a normal bilirubin, but one that is less than or equal to 0.6 times the upper limit of normal, those are the patients who do best of all. You have a normal bilirubin, but it's between 0.6 times the upper limit of normal and 1.0 times the upper limit of normal. They don't do quite so well, whereas those with the abnormal bilirubin do least well. And what's also important to know, if on URSO, if you are in that group that have it less than or equal to 0.6 times, either were there to begin with and then, or came down to that level after treatment, those are the best. Whereas the ones between 0.6 and 1.0, whether they started there and remained there or ended up there, do in between. And those patients who go normal to abnormal, as you might imagine, or stay abnormal, do least well. So it's a good number, again, to tuck in the back of your mind, a bilirubin less than 0.6 times the upper limit of normal. And all of us in this area are now reaching the understanding that perhaps we should be aspiring to the ultimate goal of treatment, which would be a Billy less than or equal to 0.6 times the upper limit of normal and a complete normalization of the alk phos. So what are the other prognostic factors at baseline? I mentioned the KPA at the beginning. Well, we know from older data that patients with advanced histology don't do as well. Now, this is all biopsy data, and this was the old Paris 1 criteria study, but what they showed is that the histologic stage of 3 to 4 at baseline put those patients at increased risk for death or liver transplantation. That was verified in a second larger cohort of patients, which again showed that advanced histologic fibrosis at baseline was an independent predictor of survival. So not surprising, the more advanced the fibrosis, the worse the prognosis. These studies showed that we don't need the biopsy to do that you can actually use non-invasive measures like transient elastography and MR elastography. And they gave these sorts of cutoffs in patients as predictors of outcome. And that was a TE of greater than or equal to 10.2 kPa on your FibroScan, or an MRE showing greater than or equal to 4.3 kPa. So I think most people are using FibroScan, so 10.2 kPa is a good number to have in your head for your PBC patients. So what is our patient's prognosis? They achieved a biochemical response on URSO. They had a bilirubin at baseline that was less than 0.6 times the upper limit of normal and stayed there. She had a low baseline KPA, certainly less than 10.2. How about this issue of asymptomatic? I mentioned it a couple times that she was asymptomatic at baseline, was still asymptomatic. It used to be that we put a lot of stock in patients who are asymptomatic having better prognosis. That's not as clear anymore. There's been some data which seems to conflict with that or contradict that. So it's still important to ask your patients if they're symptomatic between fatigue, pruritus, sicca symptoms. But maybe not put quite as much stock in it as we used to. So let's think about this. How might we manage this case differently if our patient at baseline looks very different? So let's say they started and had an alk phos of 600, AST 90, ALT 95, and a Billy of 1.3, had a FibroScan with a KPA of 11.2, and after 6 months of URSO, that alk phos had only gone 600 to 400, and transaminases came down, but still were far from normal. And the bilirubin came down just a little bit. So this is a little tougher nut to crack. Well, there actually is a case being made to assess URSO response before 12 months. Remember, all those response criteria models had at least a minimum of 12 months. Why would we want to push this? Well, we don't want to delay second-line therapy in patients at the highest risk for decompensation, so those patients with advanced fibrosis. Data actually suggests that URSO non-response can be reliably predicted after 6 months, and using a very arbitrary cutoff of 1.9 times the upper limit of normal. What these investigators found was that you could identify those who are ultimately going to have an insufficient response in 2/3 of the patients at 6 months. So 210 of these patients would have been identified at 6 months, whereas 103 would not. So 210 out of just over 300 is where that 67% comes from. So this is important because picking up these patients earlier and intervening earlier can have great meaning. So what if we decide we've got somebody who requires a second-line therapy? What are the current options that we have? And the FXR receptor agonists are the second-line therapy at the moment. A beta-cholic acid, or OCA, is a steroidal FXR agonist that was approved by the FDA on May 27, 2016. It is modified from chenodeoxycholic acid, but with a much higher affinity for the FXR receptor. It works by decreasing bile production and increasing bile secretion and flow. It also seems to have some anti-inflammatory and anti-fibrotic effects. The hard part is that pruritus is a common and often treatment-limiting side effect of beta-cholic acid. So what does the data show us? And this is the POISE trial, which was the phase 3 pivotal trial for OCA. And what they used as the primary endpoint, and here's where those numbers come in, they looked at the percentage of patients achieving an alk phos less than 1.67 times the upper limit of normal and a T-Billy less than or equal to upper limit of normal. And you had to have an alpha decrease of greater than or equal to 15%. The reason logic for that was that if you had somebody who was 2 or 3 points above the upper limit of normal, and then went 2 or 3 points below, is that really a meaningful difference? So with that in mind, this only looked at non-responders to URSO or an inability to tolerate URSO. And when you looked at the percent of responders, you can see that it was around 47, 48% in the OCA group, compared with the placebo group, which was around 10%. Now, this is going to be important as we look at some of the other trials. But that number, if you do the delta from the placebo, it's going to be somewhere in the 37% range difference between the two groups. It's also not 100%, and this is really important to keep in mind. So there are still going to be potentially patients after a second-line therapy that may need to be considered for a third-line therapy. There are also going to be patients who don't respond to the second-line therapy, in which case that therapy should not necessarily be considered. We need to hold it to the same standard we hold any other therapy. So if you're not reaching treatment response, then it should be stopped. Here's the new kid on the block, the PPAR agonists. These are going to be important for you to know about, as there are a couple of them that are going up before the FDA this summer. So the oldest ones are fenofibrate and bezafibrate. These are both fibric acid derivatives. What's fascinating about these drugs is that the other three that are being developed are not fibric acid derivatives, but they're all PPAR agonists. There are 3 different PPAR receptors, gamma, delta, and alpha. And as you can see, every single one of these drugs works on a different group or grouping of the receptors. Yet there seems to be benefit there. So it's very interesting to think about how these drugs work and the differences that are present. If you look strictly at the fibric acid derivatives, particularly fenofibrate, which is available as an off-label therapy in the US, it's important to know that it can be associated with bumps in the ALT and the AST, even as the alpha is coming down. It can increase serum creatinine, but without impacting GFR, and that's really important. So what it's doing is not actually causing kidney dysfunction, but rather it seems to be slowing the uptake of creatinine into the kidneys. And the 2 main side effects really are myalgias and heartburn. I never had a patient who I've needed to stop treatment for these side effects, but certainly have seen the top 2 in terms of the biochemistry. So these are available. How do they work? Well, through the different receptors, they seem to affect inflammatory pathways, NF-kappa B, but also they have anti-inflammatory properties and also anti-cholestatic properties. So it's a combination of those 2 things which seem to be of benefit. What does the data look like? Bezafibrate, this was the phase 3 Bezurso trial in the New England Journal back in 2018. And what they looked at was, again, non-responders or intolerance to URSO, and they put them on bezafibrate. And this was for 2 years. And their primary endpoint was actually a complete biochemical response. So they wanted normalization of billy, alphos, aminotransferases, albumin, and a normal PT. So really setting the bar much higher than they did in the POISE trial. And what they found was that with bezafibrate, 31% of the patients after that time frame reached it, whereas 0% of the placebo group did, which is what you'd expect. So this is now approved in Europe and in Canada. It's potentially going to be available in the US in combination with OCA, but we'll see. But right now, that's certainly one to keep in mind. Here are the 2 phase 3 trials which were published in the New England Journal in February of this year. So you need to know about these 2. Seladelpar is a PPAR agonist. Again, it was in patients with an incomplete response to URSO or intolerance, and they got either seladelpar daily or placebo for 52 weeks, and they had the exact primary endpoints as the POISE trial. That same decrease the alphos to 1.67 times the upper limit normal, 15% or greater reduction, and billy that was normal. And looking at this, look at the numbers. So they had actually a 61.7% group. But look at the difference in the placebo arm. So it was 10% in the OCA group. It's 20% in this one. So if you look at the delta, it becomes 41.7%. Also, if you look at normalization, the seladelpar group did well with 25% versus 0 for placebo. Here's the key thing with the PPAR agonists is that unlike the FXR agonists, which provoke pruritus, seladelpar and some of the other PPAR agonists are actually potentially treatments for pruritus. And so, in fact, what they showed was that seladelpar in a statistically significant way improved pruritus measures over the placebo arm. In the very same journal, in the very same edition of the New England Journal, they published the elafibranor trial, which again was structured exactly the same way. So we're comparing, at least in terms of the study itself, same endpoints. And you can see here was 51%. So on the surface, you might say, well, that seems to be less than seladelpar, yet their placebo arm was just 4%. So that's a delta of 47%. So always just, as you look at these numbers, it's important to think about them. Likewise, with seladelpar, elafibranor seemed to improve itch, although it did not reach statistical significance, whereas seladelpar did. So very subtle differences. They both seem to be very effective therapies, and they both seem to improve itch as opposed to worsen itch. There are other subtle differences in the studies that we don't have time to talk about. So let's say that you have a patient who has partial response to one of these therapies. Is there any role to add the third class of drugs? So let's say they were on OCA, got a partial response. Now you don't know what to do. Well, could we add a PPAR to the FXR? Or could we add an FXR to the PPAR? And the answer is yes. And there's a study which looked at this very question, and they found that triple therapy was actually associated with additional reduction in the alk phos. So there may be a role for triple therapy. So I'm going to quickly go through this updated treatment algorithm for PBC. We published this in the American Journal back in 2023. It's going to be changing, of course, and I'll show you an updated one with potentially seladelpar and elafibranor. But key points here I want you to take home. At baseline, stage your patients. Used to be we had biopsies on all of them. Now it's really important to get a fibroscan. You want to know if your patient is at higher risk for decompensation. And the reason you want to know that is that you want to be thinking, may want to reassess at 6 months in my high-risk patients. They have a transient elastography greater than or equal to 10.2. The key point, they have to have compensated liver disease and no signs of portal hypertension, things that would maybe make it so you don't want to add a second-line therapy. But if they fit these criteria, you want to think at 6 months if they're high risk. And we set pretty high bar here to say, do we add a second line therapy? Because these are the patients you're worried most about. If they are in a better place, like our patient, you could wait to 12 months and apply the standard criteria to determine response. Then right now, the key question for you might be, do they have significant baseline pruritus? And if the answer is yes, as opposed to going to the obeticholic acid, you might say, well, I'm either going to think about using fenofibrate off-label or referring them to someone who would discuss the use of off-label fenofibrate, and that certainly can have benefit. Otherwise, you're going to use obeticholic acid, titrate as recommended, which is start at 5 and titrate 10 at 3 months, depending on the response. And now the next key part is that if you have on double therapy a partial response, maybe consider the addition of triple therapy. So there are things that are clearly changing here. Here's the potential future algorithm. I won't spend a great deal of time on this because a lot of it's the same what we just looked at, but stage your patients before treatment, determine your high-risk patients, in which case you're going to reassess them at 6 months. Don't wait for the full 12. And if they aren't, and then you would think about perhaps adding either elafibranor, seladelpar, or OCA as your second-line therapy if they are non-responders to URSO. And here again, if they have partial response to whichever the two you chose, maybe add the third onto it. If you have no response, you flip it over and go to the other class of drugs and reassess. So conclusions quickly. URSO is the cornerstone of treatment and is used regardless of stage of disease. Identifying your patients who are non-responders to URSO is critical. In patients with more advanced fibrosis, consider assessing for non-response at 6 months, not 12. Additional drugs should be used for non-responders to URSO. OCA is FDA approved, currently accepted as second-line therapy in the US. Bezafibrate is approved in Canada and the EU. Fenofibrate is available for off-label use in the U.S. And when available, elafibranor and seladelpar likely will be accepted second-line therapy with OCA third line, although OCA can still be used as second line. Second case, 34-year-old man who you follow for uncomplicated UC develops mild pruritus and is noted to have abnormal liver enzymes. So the alk phos is elevated, ALT and AST are up slightly, T-bili is up a bit, albumin and total protein are normal, as is the CBC. Only past medical history is their UC. They're on the 5-ASA, and their physical exam is unremarkable. So, of course, all of us are thinking immediately, well, this patient may have PSC. And from the guidelines, the ASLD guidance document in 2022, now, of course, MRI, MRCP is the next step. ERCP is never used as a diagnostic test anymore. And what you're looking for when you tell your radiologist, here's the test I want, you're, of course, looking for biliary strictures. If you have biliary strictures, can we jump and say it's PSC? Well, no, you always want to say, let's be certain there are no causes of secondary sclerosing cholangitis. That needs to be considered. And as a pearl, every patient with newly diagnosed sclerosing cholangitis should have checked as part of their initial evaluation CA19-9 and IgG subtypes to look for IgG4 disease that would be treated very differently. So it's really important to jump to the diagnosis of PSC. So in our patient's case, the CA19-9 is normal, IgG4 normal, MRCP suggests a CBD stricture. So here's your next question. Which term is correct for the radiologist to apply to the perceived CBD stricture? Is it a high-grade stricture, a dominant stricture, or a relevant stricture? And this is important for you to know the difference, and I'm still educating our radiologists on this, and they're getting there. But a dominant stricture is actually a term that's reserved for use by our interventional endoscopists, because what it is it's a stricture with a diameter of less than 1.5 millimeters in the CBD or less than 1 millimeter in the hepatic ducts, as measured on ERCP. So the only way that you can really call something a dominant stricture is if there's an ERCP. A high-grade stricture falls in the realm of the radiologist, and this is a stricture of the common bile duct or hepatic ducts with a greater than 75% reduction in diameter as measured on the MRCP. The relevant stricture falls within our realm as GI and hepatologists, and it is any stricture of the CBD or hepatic ducts that's associated with signs or symptoms of obstructive cholestasis and or bacterial cholangitis. So it's actually important to think about using these terms correctly. So what intervention should we ask our endoscopist to employ if there is a dominant stricture on ERCP? And our choices are, do we ask them to do a balloon dilation or do we ask them to stent? And this was answered in a study published now back in 2018, which was a study from Europe, the DILS stent trial, which very simply looked at single balloon dilation versus short-term stenting to treat strictures associated with PSC. The study was prematurely stopped. The interventions were actually equally effective, but there was a significantly higher serious adverse event rate in the stent group. The patients were more likely to get pancreatitis and bacterial cholangitis. So clearly the best choice is to do balloon dilation, not stenting unless it is required. I never give my interventional guys a hard time if they felt there was an indication to leave a stent in, but ideally we avoid it. So here's our patient. So here's the distal CBD, and there's this long stricture in the CBD leading up to the level of the cystic duct. In fact, nothing above the cystic duct is filling on this initial study. So in addition to dilating the stricture, what testing should we ask our endoscopist to send? And so when they do their biliary brushings, of course, they're going to do standard cytology, but also now standard of care for these patients is to ask them to send a FISH test, fluorescence in situ hybridization. This is a send-out test. It goes to the Mayo. It can be done out of any endoscopy center. So if it's one that's not currently available where you are, you need to talk to your endoscopist and your pathologist and get that set up, because really that's a very important part of the evaluation of these patients. So what is FISH? Well, it certainly adds to our sensitivity and specificity for identifying cancer in these biliary strictures. What it is fluorescently labeled DNA based on probes, base probes to detect chromosomal aneuploidy in cholangiocytes. So as you might imagine with chromosomes, each cell should have two signals for each of the four probes. So when you have the two signals, this looks pretty good. But what happens then is that if you have polysomy, many extra copies, you guys can see how busy these cells are. So a FISH assay is considered positive when 5+ cells display gains of 2+ chromosomes. Now, there are important factors to consider when interpreting a positive FISH. A single positive FISH may as yet not be bad. So if you looked at this in this study, here was a patient who had polysomy FISH, but no definite cholangiocarcinoma on imaging. On follow-up testing, it was all no FISH negative. So in those cases, 82% will be benign, 18% went on to develop cholangiocarcinoma. If you had serial polysomy, so every time you assessed a stricture, it was coming back with a positive FISH, now the likelihood of cholangiocarcinoma jumped up to 69%. Likewise, if you found that you had, say, strictures in the CBD, the common hepatic, and the right side, and all of them were coming back with positive FISH, you can see here, this is survival-free of cholangiocarcinoma. The patients with multifocal polysomy did terribly, whereas if you had a unifocal polysomy, you did better. So the point is, these are two important things. Not only is it a single positive FISH, is it can I replicate it, and in how many spots in the biliary tree was it? So your endoscopist needs to be doing more than one FISH if there are more than one stricture. This issue of screening for cholangiocarcinoma and PSC is another really important one. It is now standard of care to have a surveillance strategy for your patients with PSC. But it's also really important to understand that any strategy needs to reflect the heterogeneity of the risk. So one size does not fit all. It's not like our cirrhotics, we're screening for HCC. What is the difference? Well, if you have large duct disease and it's complicated by relevant strictures, especially those with IBD, 80% have IBD along with their PSC, whereas 20% of PSC patients do not have IBD. But if you have both, the recommendation is an MRCP and CA19-9 at least every 12 months, but in some of those patients, in my practice, they'll be getting it at 6-month intervals if I feel the risk is high. If you have large duct disease without relevant strictures, now you can do it every 12 months. If you have small duct disease or happen to have a pediatric patient, those are patients who are at no increased risk of cholangio. So the teaching here is that you do an MRCP every 2 to 5 years. So why do you do it? In small duct disease, the reason is you're trying to assess for a transition to large duct disease that would then mandate you need to move on to annual surveillance. So think about your patient as an individual and what surveillance strategy is best for them. How about treatment for PSC? I don't have to remind this group, there is no FDA-approved therapy for PSC, but treatment of any form, pharmacologic or endoscopic, that produces biochemical improvement is potentially a benefit. There are lots of studies like this which show regardless of how you get there, if you can get the serum alkaline phosphatase to improve to less than 1.5 times the upper limit of normal, those patients do statistically significantly better than the ones who have persistent elevation of the alk phos. So the point being, your goal should be, by hook or by crook, I want to get my patients' numbers better. So what are the options? Well, here's what the possibilities are. There are a lot of bile acid-based therapies, PPARs and FXRs. So the big ones here, URSO, FXR receptor agonists, and one of them, silofexor, actually was tested and failed. And our old friends, the PPAR agonists, they all potentially improve the alk phos. So could be considered, because we know if we improve the alk phos, the patient might do better. Microbiota-based therapies, both antibiotics, particularly oral vancomycin and fecal transplantation, none of in absolute proven ways, but we see that these things can improve the alk phos signal, so maybe a benefit. Every immune modulation therapy we've tried has failed, everything. So there's no role there. But some of these are potential. URSO could be used off-label. Fenofibrate could be used off-label. Oral vanco could be used off-label. So there are things here that for patients you're concerned about and they're progressing, you might consider as options. The perfect treatment would be to have both. a drug with both anti-cholestatic and anti-fibrotic effects to deal with those strictures. So I'm going to wrap it up with some conclusions here for PSC. There is still no proven medical therapy. Urso may improve liver biochemistries and should be considered for a trial in all patients with PSC, given the improved outcome in those patients who do have improved biochemistries. I would suggest you consider referral to expert centers for consideration of off-label therapies in clinical trials. There have been a number of exciting recent clinical trials in PSC. So if you have interested patients, please send them to whatever local expert center you have. Dilation and sampling of relevant strictures is recommended. FISH should be performed on all biliary brushings. And surveillance for cholangiocarcinoma in patients with PSC is now generally accepted as standard of care, but consider your patient's individual characteristics to come up with a plan that is best for them. And I'd like to thank you for your attention.